So I think we have most folks on our side. So maybe I'll just give it one more minute and then we'll go ahead. I'll introduce you and then I'll let you get started.
Yeah, that sounds good. Happy for you to start if you're ready on your end.
Okay. So everybody, thank you all for joining our lecture. Our students have lectures on Tuesday and Thursday afternoons, and so they've been in quite a few lectures today, kind of learning a lot about HIV and Hep C health disparities. And so today we're very lucky that we have Dr. Natasha Martin with us. And she is an infectious disease economic modeler who develops dynamic transmission models to evaluate the impact and cost effectiveness of public health interventions. She's a professor in the Division of Infectious Diseases and Global Public Health at the University of California, San Diego. I've had the pleasure of getting to know Dr. Martin through some of my work. She's done a lot on kind of modeling kind of the impact of diseases. And so on a research grant that I have looking at hepatitis C in incarcerated persons, and I think I talked to you all a little bit about this when I did the initial Hep C lecture. You know, we're doing kind of this Hep C testing and treatment program in corrections. But one of the things is I'll have data kind of in real time on what we've done, but we want to look out in the future and predict, you know, kind of 5 years from now, 10 years from now, what would be the impact of that programming. And Dr. Martin is able to help us do that with the data we collect, kind of model the impact and look at what that would do to kind of mortality outcomes or overall reaching some of our hepatitis C elimination goals. And so she is kind of the person on my grant that'll be helping us kind of figure all those things out. And she's done a lot of work in this area. So I'm going to turn it over to her and let her present to you all now.
Thanks so much, Risha. It's really a pleasure to be here. So, you know, as Risha mentioned, we have worked together on this hepatitis C elimination grant, which I'm really excited to be part of. And it's really nice to see the sort of Center for AIDS Research is working together. I am at UC San Diego, and I co-direct the biostatistics and modeling core of our Center for AIDS Research, which means that we really try to think of ways that we can use both statistical analytics, but also what I'll be talking about today, which is more modeling and epidemic and economic modeling to support HIV research. So just a quick show of hands here, just so I can gauge kind of experience. So if I was to say today, I'm going to be talking about COVID models and COVID modeling, how many of you feel like you would have a good idea of what that might mean generally? Like when I say a COVID model, just a show of hands. Okay, a few. And how many of you would be like, I have no idea what that means, that just, I can't even envisage what a COVID modeling might be. Okay, great. Okay, so the reason why I ask and I use COVID as an example is that it's been the most recent and most visible way that epidemic modeling has been kind of disseminated and talked about in the public press. And so there have been a lot of research groups over the last couple of years that have used the methods that I'll be talking about today, which are epidemic modeling methods, to do things like forecast the number of new infections of COVID or the number of hospitalizations that we might have in the next week, in the next month, in the next few months, right? And to use those models, not just to forecast, infections and hospitalizations and deaths, but also to use those models to try to think about what could be the potential impact of interventions like stay-at-home orders or masking in the population. And, there's been a lot of discussion and criticism, I think much of it founded, of the uses and the limitations of those models, right? And we can talk a little bit about that today as well. But in general, I think they're very helpful they're a helpful sort of quantitative framework for us to try to predict what might happen in the future based on what we've observed in the past and our understanding of the dynamics of those infection, the natural history of infection, how the infection spreads through the population, and also to conceptually think about what the impact of different interventions could be and what the implications could be in terms of economic and cost. So I'll talk a little bit about that today. So let me bring up my slides. Yeah, let's see if I can get these going. So today I won't be talking about COVID. I'll be talking about HIV and hepatitis C virus, more about HIV to be honest. And I'm going to talk about two things. The title of my talk said epidemic modeling. That's true. But I decided I wanted to throw in a little bit about economic modeling as well. It's basically layering the costs and the health benefits on top of this epidemic modeling framework to help us understand not just the population impact of interventions, but the economic impact of our different interventions. And those two pieces together are really critical information for policymakers when they're trying to decide between different courses of action. And today I'll be talking in particular about HIV and hepatitis C prevention among substance using populations. One of the reasons why I chose the examples that I'll show you today are that they're really nice examples of work that's been done by members of my team, both here at UC San Diego, you'll see their names on this slide, but also at Johns Hopkins. So I work with a former trainee who was here at UC San Diego, but is now back at Hopkins, Javier Cepeda, and he's collaborated on much of this work. Okay, so my talk here is split into kind of three sections. The first part is just to give you a very general overview background of what do I mean when I'm talking about epidemic and economic modeling for those that aren't really familiar with those concepts. And then I'll talk a little bit about the topic area of the examples that I'll be showing you today in terms of those modeling methods and how they can be applied to HIV and hepatitis C virus prevention making. Because what I'll be talking about is policing exposures and how interactions with the criminal justice system can fuel HIV and hepatitis C among people who inject drugs. And then I'll show you two case studies where we have modeled the impact of drug reform on HIV transmission and incidence among people who inject drugs. And we've also used modeling work to model the population impact of and the cost effectiveness of an intervention. And that intervention is a police education program that happened in Tijuana, Mexico, near where I live. And using modeling to project the impact and the cost effectiveness of that police education program on HIV and hepatitis C among people who inject drugs. Okay, so starting first, economic and epidemic modeling. What are these models that I'm talking about? So the difficulty with the word modeling is that it can mean so many different things, and it's often used to mean different, there's different types of models and they can do different types of things. And so I'll break it up into two very basic classes of models. There are other types of models, but these are the two kind of classes that I want to draw a distinction from today. The first type of models are called statistical models. Those are models that just describe associations between variables. So anyone here that's done a regression analysis where you're just trying to see is A associated with B, that would be a statistical, you build a statistical model, and it might be something like, well, we wanted to investigate whether HIV acquisition is associated with sharing of unsterile syringes, right? Or does being on opiate substitution therapy, is that associated with a reduction in the risk of acquiring HIV? So we're just looking at relationships between two things and whether we can see a relationship between them. That is not what I'll be talking about today. Although statistical associations are very important information that we often use as inputs to our models, our dynamic models. But what I'll be talking about today is something called a dynamic transmission model. These are also often called epidemic models. And what these models do is they provide a mechanistic representation for how an epidemic is established. So because it incorporates this mechanism and mechanistically generates the epidemic, it can be used to simulate into the future. And that's what dynamic models or epidemic models can do that statistical models cannot, because statistical models are just looking at associations between two variables. So these dynamic transmission or epidemic models allow us to project the epidemic forward through time and under various conditions. So you can see here on this slide, I'm showing a picture of a model that Dr. Cepeda developed that was simulating HIV transmission among people who inject drugs. It was calibrated to data on HIV prevalence among people who inject drugs in a setting in Russia. And you can see these dots here are the data points. That's surveillance data. That's real data of, you can see increasing HIV prevalence in the early 2000s among people who inject drugs, and then stabilized through 2010. And these lines here are the simulated model projections. So what we do is we build this dynamic model that incorporates the mechanism of transmission in this population, and then we calibrate the model. We ensure that the model fits the data and moves through these observed trajectories, and then we can simulate out into the future, which is what you're seeing here on the right-hand side. And the different color lines are just different simulations of interventions to look at what impact that might have on HIV. Okay, so why do we need these dynamic transmission models? Why can't we just use statistical associations, or why can't we just look at the observed epidemic in terms of new cases or prevalence and be able to assess what is going to happen in the future? Well, I think people are kind of familiar with this because of COVID, but the answer is because infectious diseases are infectious, right? And these infectious patterns change over time as the disease spreads. So the incidence, or what we call the number of new infections, some people, some people might say, well, why can't we just see what incidence was yesterday or last year and assume it will be the same in the future? But of course, we know that's not true, right? So I walk into a room, we're virtual now, but let's say we were holding this lecture in person next year, and I have the flu, and I come in and I infect one person, and then we come back tomorrow, maybe for a discussion section, and the two of us come back, we're both still sick, and we infect two more people, right? So yesterday there was one new infection, today there's two new infections, tomorrow if we come back there may be 6 new infections, right? So the number of new infections, the incidence, is changing day on day. And that can actually change for a lot of different reasons. It can change because the infection is just naturally spreading through our population. It can change because there's demographic changes in our population. Let's say my lecture is really boring, and so only half the people come tomorrow to the discussion section. Then obviously that we're going to have a different number of new infections tomorrow than we would have had today. Or if everyone loved my lecture and we have 20 more people that join us tomorrow, that will change it, right? The demography of the population. But also there can be behavioral changes. Like you came to this lecture today, you saw I was sick, you come back tomorrow and everyone is masked, right? That is going to change the incidence. So, and of course, it could be interventions, treatments that might affect whether we're transmitting. So there's a lot of different things that can affect what we might expect to see tomorrow and in the next days and weeks and months in terms of these new infections. And so we really need a dynamic model, a model that incorporates these mechanisms of contact and intervention and demography to be able to predict and understand these dynamics. Okay, so why do we need these models? We need them because infectious diseases are infectious, as I mentioned, and because preventing one infection doesn't just prevent an infection to that individual, it prevents a whole chain of onwards infections. And so we need a model that's able to simulate out that chain of infections so that we can understand how breaking that chain could affect the epidemic in a month's time or a year's time. And therefore, using this mechanistic framework, it allows us to understand not what is driving the epidemic, what are some of the behaviors that or actions that might be driving the epidemic, and allow us to predict long-term population level impact of interventions. So we move from associations like Sharing of unsterile syringes could contribute to HIV transmission. To population impact is saying, well, what if we reduce syringe sharing by 10%? What impact could that have in reducing the number of new infections we might expect to see of HIV over the next year or 10 years in this population? And it's also useful in estimating not just the long-term impact on our population in terms of health, but also the economic implications. How will this affect the number of people that I have to treat for HIV in 10 years and the economic costs? And how does it affect the cost effectiveness of different interventions? So if I have this new novel intervention to link people to care, how cost effective is that in terms of the population benefit it will have, as well as the associated costs? And again, these are the things that policymakers really care about, not just impact, but also cost. So in terms of cost, let's go back to that. So I'm talking about epidemic modeling, but I'm also talking a little bit about the economic implications and economic modeling. And I like to show this comic. It's a Dilbert comic. He says, "I reject your idea because the costs are high." And Dilbert says, "In a one variable world, you would be a genius." Right? And so this is what I think modeling is the key framework that takes us away from this one variable world, which is I only care about cost, right? And brings us into a world where we can talk not just about the cost of things and the cost of interventions, but the benefits of those and the long-term benefits. I'm going to pay this much money for an intervention today because in 20 years, I'm going to prevent somebody from dying from HIV. Right? I might prevent them from getting HIV and then subsequently dying, or having to pay for ART for them in 15 years. So we're taking costs and we're building a framework where we can say, well, what are the other benefits of these interventions? And it may not just be on HIV. Maybe your prevention intervention prevents not just HIV, but also viral hepatitis and overdose and all kinds of different outcomes. Well, we can build models that are able to capture all those benefits. And now we can have a really sophisticated discussion about whether you should invest in this HIV intervention because you have all these different benefits, and I can quantify that for you. Okay, so why do we need this economic evaluation? Why do we need this framework that can look at costs and look at all the health outcomes and benefits? Well, if we lived in a world where we had unlimited resources, then we probably wouldn't need this. But even in the US, we have finite resources. And so we need to know what is the best use of the money that we have. There is an opportunity cost for every choice that we make, every dollar we spend. We are spending it somewhere and not spending it somewhere else. And so we're constantly thinking about these opportunity costs in terms of if we spend $1 here, would that dollar be better spent somewhere else? And so modeling can be used to talk about efficiencies. Not do we spend less? Not how can we spend the least, but how can we get the most for the money that we're spending? Okay, we're trying to maximize the impact of every dollar that we spend. And this is a really important point. So the goal of an economic evaluation or economic modeling is not to say we shouldn't spend money or let's spend the least. It's to spend the least. It's to identify value for money. And again, to say, let's spend as much money as we possibly can, but get the most value out of that money. And so even if an intervention is effective, even if we have an intervention that has a known benefit, governments want to know how much will it cost? Yes. But is it good value for money? Is it cost effective? Am I getting the most from spending that dollar on this intervention compared to a different intervention? And that's what this modeling framework can tell us. And so with a model, we can place our intervention on this plane. And it's a little bit complicated, but don't get too bogged down in all the words on this slide. I'll walk you through it. So here on the x-axis here, we're looking at whether a treatment or an intervention is more or less effective than what we're doing now. So things that are more effective on the right, that's where we want to be. If it's less effective, we don't want to be over here, obviously. But it can also, that intervention or that treatment could be more costly. That's what we're looking at on the y-axis here, or it can be less costly. Now, a great intervention would be one that's more effective and less costly than what we're doing before. That's over here, we're down here. And that's an intervention that's what we call cost saving. That's great, but it's not necessarily the goal. We are often in this space here where we're looking at things that are hopefully more effective, but they're also more costly. And so we want to know, is it that good value for money, right? Is it here? This is basically the area of the curve where it's more effective, but it's worth the cost. It's considered worth the additional amount of spend. And the economic models that we developed allow us to see where we are on this plane and whether we're in a place where it's either, well, hopefully cost saving, that would be great. But if it costs money, is it worth the money that we spend? So cost effective doesn't mean cost saving, doesn't mean we're saving money. It just means that it's worth the money that we're spending on it compared to what we could spend that money on in some other domain. And the last sort of overview I'll give you is I wanted to break down for you what this output is when we're looking at cost effectiveness, because it relates to one of the examples that I'll show you later on. So when we're trying to determine if an intervention is cost effective, we are usually comparing two things. A new strategy, maybe compared to what we're doing now. And we calculate what's called an incremental cost effectiveness ratio. And actually, it sounds complicated, but it's very simple. It's just the difference in the cost of the strategy divided by the difference in the health benefits of the strategy. So it's the incremental cost divided by the incremental benefit. And often this is sort of displayed as something like a cost per, if you've heard, quality adjusted life year gained, or cost per infection averted, right? Is the incremental cost per the benefit worthwhile? And we calculate this what we call an ICER, for short, incremental cost effectiveness ratio. And if that number is below what the government or the payer is willing to pay, this willingness to pay threshold, then the intervention is cost effective, right? And this is kind of confusing because it's the smaller the better, right? The smaller means we're paying a small amount per health benefit, a small incremental cost per our health benefit. And so the lower the number, the better. If we have a very, very high ICER, it means we're paying a lot for that incremental health benefit. And so if our ICER is below some arbitrary threshold that's set by either a funder or payer, intervention is likely cost effective. And if it's above that threshold, then it's not cost effective. And that helps us give us a guide on whether or not, this intervention is a good investment. Okay, so I've given you a little bit of a background on modeling and health economics. And now I want to really break it down for you and show you an example of what this means and how we've applied this work, in particular in thinking about health among people who use drugs. And a lot of what my team does is look at policing exposures and how those can fuel negative health outcomes among substance using populations, and how we can develop interventions and frankly, better laws and policies so that doesn't happen and we can actually improve health in this population. So you may have seen this conceptual framework. It's thinking about, it's the conceptual framework of the layers of drivers that can contribute to HIV transmission, from individual actions that people make, to their interpersonal networks, to their community networks, to institutional and health system frameworks that can fuel transmission, but also structural drivers of HIV transmission. This is the largest bubble here. And I know there's a lot of words on this slide, but what I'm trying to do here is take you away from thinking about individual things. For example, I was just talking about individual factors, sharing of unsterile syringes and how that can contribute to HIV. But now I want to bring you out to thinking about more structural factors, laws, how criminalization of drug use can fuel environments that people who inject drugs are living within that fuel HIV transmission. And so what I'll be talking about today is how criminalization of drug use and subsequent police interactions can actually increase risk of bloodborne viruses and other health harms among people who inject drugs, and how we can use modeling to quantify that. So we have accumulating evidence that criminal justice interactions act as drivers of HIV, hepatitis C virus, and tuberculosis transmission. And this can happen directly here. This is a picture of some police interacting with people who inject drugs in Tijuana, Mexico, just right across the border from San Diego. And those negative, those interactions often that are associated with assault, can lead to, can fuel sort of risky injection practices, and directly fuel HIV transmission. But incarceration itself serves to disrupt networks. People are obviously disrupted out of their social networks. They're incarcerated. They are concentrated together, and often do not have access to harm reduction interventions that they might have access to in the community. And therefore, while they're in prison, they may experience higher risk of HIV and hepatitis C. And we also know that the periods post-release, after release from these carceral settings, are also very high periods of risk, where again, those networks are disrupted, and people who inject drugs experience very high risk of overdose in the first 2 weeks after release from prison, and also high risk of acquiring HIV and hepatitis C in that period. So all these interactions can fuel negative health harms. And there was actually a global systematic review and meta-analysis by some colleagues of mine that was done a few years ago, published in Lancet Infectious Diseases, that found, they looked at studies across multiple global settings, and then they pooled all the data together across these multiple cohorts. And they found that recent incarceration significantly increases the risk of acquiring HIV by about 80%. And hepatitis C virus by about 62% among people who inject drugs, compared to those who had been non-recently or never incarcerated. And that risk actually persists post-release. So people are still remain at elevated risk after they're released and have not recently been released from prison. So we see, again, evidence that these exposures are associated with HIV and hepatitis C risk. Now, this was done looking at statistical associations, but we can use these statistical associations to feed it into models to try to understand, well, what does that mean in terms of the contribution based on what proportion of people who inject drugs are exposed to incarceration and how long they're exposed to incarceration. We can use modeling to try to understand, well, how much is incarceration contributing to HIV transmission and incidence. And so this is an example of some work that our team did that was published in the Lancet a few years ago. And this is using a dynamic model I was talking about before. So it mechanistically simulates transmission of HIV among people who inject drugs. And using these statistical associations I just showed you in terms of the increased risk of HIV and hepatitis C acquisition, if you're exposed to incarceration, we can use it to estimate the contribution of incarceration to new HIV infections over the next 15-year period. So this is a simulation work that was done in Ukraine, where we estimated between maybe as much as 55% or over half of new infections, HIV infections among people who inject drugs in Ukraine could be due to incarceration. And some other more conservative projections indicated that maybe this was a third. So between a third and a half of new HIV infections associated with this structural exposure, right, incarceration. Now that's going to vary by epidemic setting and by settings where people are maybe exposed to different amounts of incarceration. This is a study done in Kentucky, and it's looking at hepatitis C virus. And here we showed that basically a quarter of new infections over the next 15 years of new hepatitis C infections among people who inject drugs could be due to incarceration. And so here we're seeing really substantial fraction of new HIV and hepatitis C infections in these populations attributable to exposures, the criminal justice system. Okay, so now I want to take you to a specific case study and some work that we've been doing here closer to home, looking at the impact of Mexican drug law reform and a subsequent police education program on HIV and hepatitis C transmission among people who inject drugs in Tijuana, Mexico. So as I mentioned earlier, I work at UC San Diego. San Diego is in Southern California, right on the border of Mexico. And so our border entry from San Diego to Mexico is here on this map at San Isidro. This is in San Diego. And then right across the border is Tijuana, Mexico. So from where I sit at UC San Diego, it takes about 20 minutes to drive to the border. It's really a contiguous, it's a contiguous city. And this is one of the major drug trafficking routes of drugs from Mexico into the United States. So it's a major drug trafficking route for heroin and methamphetamine into the US. It's a very important port of entry of drugs. And there's about 10,000 people who inject drugs who live in Mexico. About 80 to 90% of them are infected with hepatitis C. And about 5% of them are infected with HIV, although it has one of the highest incidence rates that we see in global populations. So policing practices have been well documented in Tijuana, leading to human rights violations, and abuses perpetrated by the police are typically are unaddressed, very pervasive. There's both sexual violence that's been reported, extortion, verbal and physical harassment. And these policing encounters, such as arrest or syringe confiscation, condom confiscation, have been robustly associated with elevated risk behavior. We have a number of longitudinal cohorts of people who inject drugs and female sex workers and men who have sex with men that have been working for the past 15 years in Tijuana, documenting exposures to these negative police interactions and how they are associated with increased risk and increased levels of infectious diseases. And much of this is due to laws and criminalization of drug use that sort of creates the environment for these police interactions to happen. And the war on drugs has been known to actually have failed really in many ways and resulted in an increase in the prison population, an increase in law enforcement resources. So really increasing the burden to both the security system, but also the health system, and is associated with increases in illness, both among people who use drugs, but also among their broader communities. And it's been ineffective in reducing the prevalence of drug use and the prevalence of drug-associated crime. And subsequently, there are several countries and states within the United States that are in the process of reforming their drug laws. And Mexico was one of those countries. And actually, way back in 2009, they had a series of drug policy reforms where they decriminalized small amounts of drugs and implemented referral to drug treatment on the third apprehension. So basically what happens is that police find people who have drugs. These drugs are weighed. If they're below a threshold, then they're released. But if they're apprehended 3 times, they're supposed to be referred to drug treatment. And so this was meant to kind of decriminalize possession among people with small amounts of drugs, and drug trafficking laws remained the same. So this was really public health oriented in spirit. And in many ways, we were optimistic that this might actually lead to reduces in HIV and hepatitis C for these reasons. So the reform had a provision for decriminalization. So we speculated that that might reduce incarceration among people who inject drugs and reduce police harassment. And we know that interactions, both incarceration and police harassment, have been associated in our cohorts with increased risk of syringe sharing and increased acquisition of HIV and Hep C. So thinking that decriminalization might reduce these exposures and therefore reduce these negative health outcomes. As well, I mentioned that there was a mandate for drug treatment at the third apprehension. And so we, if that drug treatment was evidence-based opiate agonist therapy, we know that opiate agonist therapy reduces the risk of acquiring HIV, and therefore any expansion of that would actually reduce HIV transmission. So these are our theoretical kind of framework for this. But unfortunately, what we saw as this was implemented and monitored in the cohorts of people who inject drugs is that there was a policy implementation gap. And this happens often where there's a gap between what the law is on the books and how it's written and how the law is implemented on the streets. There's always some gap, but it's especially dramatic in places where there's weak rule of law or weak police management. And so what we find in many settings is that policy reforms are often insufficient to actually change policing practices on the ground. And that can be due to gaps in knowledge or understanding about the laws, or also gaps in giving law enforcement officers the skills and the tools to operationalize those laws. And frankly, there's often just a little incentive to change practice based on the status quo and what they've done. And this is what we saw. Okay, so then what did we see after the reform? Well, we looked among our cohorts of people who inject drugs, and we found that there was actually no changes in incarceration among people who inject drugs after this 2009 reform. And unfortunately, there was negligible access to evidence-based opiate agonist therapy, drug treatment, before the reform and after as well. And there's a lot of other structural barriers to why that might have been the case, but nothing really changed there. And unfortunately, the government funded non-evidence-based compulsory abstinence programs instead of evidence-based opiate agonist therapy. And those programs could actually have caused harm. We did see a slight reduction in police harassment in terms of reduced syringe confiscation by the police. Syringes were actually legal to carry before, but they were confiscated by the police. But after the reform, this didn't happen anymore. So there was small changes in policing exposure. Now, why didn't we see larger change? Well, it appears to be, as I was mentioning before, when the police officers themselves were interviewed, there was little knowledge about the reform. They just didn't know about it. For those that knew a little bit about it, they typically identified mass media as where they'd heard about it, not any kind of direct information from their superiors. And they also described conflicting local laws. So there was this national reform, but then locally they had different laws and they didn't know how to reconcile that. So they just went with what was locally done and the kind of status quo. There was just a lack of education. They couldn't correctly identify. In 2015, they couldn't correctly identify the threshold where it was legal to carry. And only half of them recognizes syringes to be legal. And most of them said that they had made some arrests in terms of syringe possession. So really, there was just a lack of understanding among the police about these laws and the law change. So how can we take all this information? We have all this epidemiological data and qualitative data that sort of tells us what happened in the period after the reform. And how can we take this information and develop models to try to understand the potential, what happened with the reform and the potential missed opportunity? So what we did was we took statistical associations. This is work done by a faculty member, assistant professor here, Anique Borges at UC San Diego. And she looked at these exposure to policing interactions like incarceration and syringe confiscation. And as I mentioned, when you look statistically, you see that those having been exposed to those interactions increased the risk of syringe sharing among people who was associated with an increased risk in syringe sharing among people who inject drugs. And that's what I'm showing here. So increased risk of syringe sharing associated with these exposures. And we also looked at whether there was any increase, whether there was a dose response in terms of repeated incarceration. And this is work done by PhD student Carlos Rivera Saldán. And he found that there was an increase in syringe sharing if you'd been incarcerated, and then that went up as the number of incarcerations went up as well, which is so there's a cumulative effect as well. And so we can put those statistical associations into a model, mechanistic model, and we can use that modeling to predict the number of new infections in the future just with no reform, with the current implementation of the reform, and what if there was proper implementation? What if there was actually a reduction in incarceration, which we did not see? What if there was an increase in referral to evidence-based opiate agonist therapy? What could be the impact there? And what Anik found was that with the small change that we saw in terms of reductions in syringe confiscation after the reform happened, that likely could avert 5% of new HIV infections from the time we did this analysis, 2018 to 2030. So a small but important impact in terms of that small change in reducing HIV infections in the future. Now, what we found was that these compulsory detention programs were associated with increased risk. And so when we put that into the model, the provision and expansion of those programs could actually mean that that the total impact could have been negative, that we actually could have caused HIV infections because of increasing risk by diverting people to these non-evidence-based compulsory abstinence programs. So that could have caused harm. But if the reform were properly implemented, if we actually managed to reduce drug-related incarceration and divert people to evidence-based opiate agonist therapy who would have otherwise been incarcerated, we could prevent a fifth of new HIV infections, 20% of new HIV infections over the next 20 years. So this really shows the missed opportunity of what happened and what could be achieved. And so how do we ensure that we don't miss that opportunity, that we ensure proper full implementation of these public health oriented drug reforms? Well, a really brilliant lawyer, Leo Beletsky, who's at Northeastern University, and Stephanie Strathdy, who's here at UCSD, got a study funded by the NIH called Proyecto Escudo. And it was a police education program. And the idea was, well, nothing changed after the reform, in part because police just didn't know about the reform changes. So let's have a police education program to both tell them about the reforms, but also align their policing with public health goals. So to tell them more about HIV and hepatitis C among people who inject drugs, tell them about harm reduction, tell them about decriminalization and occupational safety in Tijuana. And so in 2015, over the course of a year, they trained the entire police force in Tijuana. That's over 1,800 officers attended this training. And then they took a subsample of those and they followed those police officers for 2 years to see whether their behaviors changed after they had received this training. So we could see among the police officers, did they report any changes in their behavior? But then we also have this parallel cohort of people who inject drugs that we could follow to see whether their exposures, they reported any changes in exposures, right? To see if those two things triangulated. And this intervention was a train the trainers model. So we train the police officers, senior police officers, and then the police officers themselves delivered the training to the rest of the police force. It was a 3-hour course. As I mentioned, it had 3 models: basic epidemiology, prevention and treatment of HIV, hepatitis C, and tuberculosis, a module on national and state drug policies, this drug reform, and a 3rd module on harm reduction, drug use, and public health. So what did they find? Well, this is work done by Javier Cepeda. And what he found was among the police officers, they reported a reduction in arrest for syringe possession and heroin possession. So the orange bars show you what the frequency, the proportion of police officers that said they sometimes or always made an arrest for syringe possession or heroin possession in the past 6 months. And before the training, the yellow bars show you 2 years after the training. We still saw a reduction in the police reported arrests for these things, and these were significant differences. So the police are reporting reductions in arrests for syringe and heroin possession. What do we see among people who inject drugs? Do we see them reporting reductions in arrests and incarceration? This is showing you the proportion of people who inject drugs at each of our sample surveys. We survey them every 6 months. The proportion who reported spending time in jail or prison in the last 6 months. So you can see before the training, a third to as much as, over 40% had reported that at some point in the last 6 months, they'd been detained or incarcerated at some point. During the training, this started to drop. And after the training, it continued to drop. And what we saw was that individuals were roughly 70% less likely to have been incarcerated after we had this Escudo intervention compared in the post-training period compared to the pre-training period. So big declines in incarceration in that group. Okay, so what does that mean in terms of HIV and hepatitis C transmission? So this is where the modeling comes in. So we use the modeling the aim was to examine the impact of that police education program on HIV and hepatitis C transmission and overdose in Tijuana. So we built these dynamic transmission models of HIV and hepatitis C. We calibrate it to the data that we have in terms of frequency of exposures and how those exposures are associated with increased risk of syringe sharing. And we also threw in the costs here because the training wasn't free. And so Javier went and collected the costs, and what he found was that the intervention cost $133 per officer trained. Okay, well, is that cost worth the benefit that we're getting? So we use the modeling to say, well, how many new HIV infections, hepatitis C infections were prevented just across the 2 years after the training? We saw those declines in the 2-year period after the training. That's the period where we were following the officers, and we know that they reported fewer arrests. We're following the people who inject drugs. They're reporting fewer incarcerations in that 2-year period. And just in 2 years, we see that the modeling predicts that the intervention prevented 13 new hepatitis C infections, 1 new HIV infection, and 16 fatal overdoses. So, all right, not a lot of HIV infections. The HIV incidence, HIV prevalence is relatively low. And we can use the modeling to say, well, what does all of this mean in terms of a total health value for the total health benefit that we're getting? And so we calculate this incremental cost effectiveness ratio that I was talking about before, the ICER. Using these models. So this tells us how much more money are we spending for our health benefit. And here we calculate when we look at just the HIV and the overdose benefits, we calculate that the intervention, remember, it costed $133 per officer trained, but what is the cost for all the health benefits we're getting? The modeling says that the intervention costs $6,828 US per disability adjusted life year averted, DALY averted. That's a composite measure that takes into account the benefits in quality of life and quantity of life across all those different things. So if I'm not infected with HIV, or if I'm not infected with hepatitis C, or if I haven't died from a fatal overdose, I can put that all into a composite measure of these disability adjusted life years. And this is what I've gotten, $6,828 per DALY averted. Okay, so then the question is that above or below our willingness to pay threshold? Is it cost effective? There's not a hard line. There's not a hard, formal threshold for Mexico. One threshold that's often taken is the per capita GDP, gross domestic product. And for Mexico, that's about $8,000. So based on that threshold, then we would say, okay, the ICER is below that willingness to pay threshold. So that intervention is cost effective. So now we've created this nice narrative because we can say, well, this intervention costs this much money to implement. You're going to get this benefits in terms of HIV infections, hepatitis C infections, fatal overdose. And this is the cost effectiveness of your intervention, and it is cost effective. And that is the information that I think really supports policymakers to say, okay, well, this intervention is worth funding and it's worth expanding. So in conclusion, overall, this talk is really about kind of drug reform and drug laws and how criminalization of drug use can fuel negative health outcomes among people who inject drugs. And so what I think is interesting is this case study that I've shown you in Mexico is that there was a law change, but it was insufficient to change the practice on the ground. And so there are often missed opportunities, both in no drug reform, but even in places where there is drug reform, there's often missed opportunity in terms of properly implementing that drug reform to prevent these downstream health harms. But what we found is that properly implemented drug reform could reduce HIV and hepatitis C and fatal overdose. And we found that by using our modeling tool. And we found that public health oriented police education program, which kind of aligns policing with public health goals, was impactful and it was cost effective. And epidemic and economic modeling were the tools that we needed to use in order to generate these arguments about the potential missed opportunity and potential impact and the economic implications and cost effectiveness. And so it's really a valuable tool to look at the population impact of interventions among substance using populations to provide the critical information that policymakers need to implement change. And finally, I just want to acknowledge my many collaborators, the participants in the study that we used, and the grants that have funded this work. And now I'd like to turn it to questions. If anyone has any questions, I'm happy to take them.
Thank you so much for that talk. I hope, students, I'll let you ask questions, but I think the big takeaway for me is that how Dr. Martin has really used kind of science to really kind of transfer over into policy and how that can impact decisions that we make. And also, in our society right now, there are a lot of contentious issues, and particularly around injection drug use and syringe services and kind of things of that nature. And so the importance of like having data to combat some of the statements that people make broadly, that like, if we have access to clean syringes, that you're going to encourage drug use. That's not true. But having kind of data like this to be able to show, and then to show the long-term impacts to people, I think is so important. But I'll turn it, Maxwell, I know you have your hand up, so.
Hi, thank you very much for your talk. First of all, I had a question on your implementation of that training program. I noticed that you did training the trainers rather than training police officers directly. What went to that decision, and what thoughts did you have before arriving on that, rather than doing direct training of officers?
So that's such a great question. I wasn't the sort of lead on that study, but from what I know about it, since I sort of worked tangentially on it, I think there were a few things that were considered. The first is that we really wanted, I think they wanted an intervention that was sustainable. And so, selecting trainers that could then deliver the training and have that kind of onwards allowed, the sort of UC San Diego team to start the intervention, but then the local teams to continue that. And it was anticipated that, obviously you might either the police may need a refresher training, or you have new officers that need training. And, I think a big important consideration when you're implementing interventions is that sustainability piece. And so that really enhanced that. But the second piece is just, who do people want to receive information from, right? And especially in systems where the when you're working in frameworks which are very hierarchical, like law enforcement, I think some qualitative information likely indicated that police themselves were more receptive to information from their superiors and not just external academics that are coming in that have, maybe less understanding of the realities of the job and implications in terms of some of the things that we're discussing to actual policing practices. So I think that not only did it make the intervention sustainable, but it made the intervention potentially more impactful to have the information delivered by trusted superiors within the police force compared to an outsider.
Thank you.
Great question. And can I add a third part? And that is maybe less exciting, but from the economic standpoint, having a sort of train the trainer model also makes it way more cost effective. Because one of the things that we did was an analysis I didn't show you is, okay, we costed out how much the intervention costed as it was, which meant developed by a binational team, but with a lot of US-based faculty members that increased the costs. But what we also looked at was, well, how much would it cost if that was then replicated across different settings in Mexico, where it could be adapted by local teams or even developed by local teams? And that was then much more cost effective and is part of a secondary argument that we're going to make in the paper when we publish. And that is that not only was it cost effective when we did it with our binational team, but it was even more cost effective if it when it's taken by local teams and then implemented. And so all of that kind of both impact and feasibility, and as well as economic benefits of having that system shift from one where it's driven by our researchers and really driven by the local staff, is an important consideration.
And Natasha, the other thing is just, could you touch on just your kind of career path for the students a bit? Our students in the program are undergraduates and kind of have diverse interests in kind of health careers. So some want to be clinicians, doctors, nurse practitioners, PAs. Some are interested in kind of public health, PhDs, kind of lots of different kind of pathways, but I'd love them to hear kind of your path.
Yeah, thanks for the opportunity. So I am a mathematician by training, but I have to say, when I was studying math, which I was always good at, I always really wanted to be a doctor secretly or work in public health. And I was never as good at my biology classes. And so I was approached by a professor in my undergraduate who asked me if I wanted to do math research. And honestly, I couldn't even envisage what that would mean, what math research was at the time. And she said, well, what are you interested in? And I said, well, actually, I'm really interested in health. And she said, well, actually, I'm working on a project that uses mathematical equations and modeling to understand cancer and human cell interactions. And actually, it's very similar models to the one I was talking about, what I presented today in terms of populations interacting and spreading infections, are the same models that we use to talk about how populations in your body, like your tumor and your immune cells, might interact with each other and cause cancer. And so I was automatically interested and started doing work in that area. But it was very much sort of fueled by a desire of wanting to apply these mathematical principles. But I will say that although my background and my training is in mathematics and I have a PhD in mathematical biology, all the students that I train at UC San Diego are either masters in public health students that don't have that mathematical background, or often clinicians that are interested in it. And there are many examples of people that came from, science backgrounds, other non-mathematical backgrounds, that have been able to build and use these models, particularly because with new computing packages, it's really easy to build these models and get them analyzed. You don't have to do it by hand, solving these equations yourself. So if you're at all interested in this, it doesn't take a PhD in mathematics to do it. And if, I'm sure if you reach out to Risha or myself, both at Hopkins and other universities have courses for people with your background, wherever you end up going, to kind of pick up these skills.
Well, thank you so much. Thank you, Natasha, for being here with us and letting us host you. And thank you to all the students as well, because I know you've had a jam-packed day of lectures, so greatly appreciate you all as well. So thank you all, and I'll save the recording and I'll send that out too.
Thanks so much. Thanks, everyone.
Thank you.
Bye.
Thank you.